All right, I think we'll get started. I see we still have participants who are coming in, but at 92. I want to welcome you and thank you for joining us for this discussion. This is Understanding and Improving COVID-19 Vaccine Uptake. Good morning, good afternoon, good evening, depending on where you are joining us from. This call or this public webinar is one in a series of webinars that are designed as a moderated conversation to help us unpack important topics related to pandemic response and with a particular focus or emphasis on lessons learned from COVID-19 and how those can impact global health policy practice moving forward. This webinar series, together with this particular one and the upcoming ones within the series, are co-organized by the COVID Advocates Advisory Board, we call it CAB, the Coalition to Accelerate and Support Prevention Research, and AVAC, that is CASPA and AVAC. And so this is building vaccine confidence in anticipation of future vaccine. The conversation is not necessarily just about COVID, not necessarily just about vaccines, but it's really situated in pandemic response and the role of vaccines within that, and looking specifically at building vaccine confidence in anticipation of future vaccines. And within that context, dear participants, we want to acknowledge that the topic of vaccine equity is quite complex. It's a very complex issue. We have seen that as advocates, as researchers, scientists, people in academia, we've seen how vaccine equity is a complex issue. It includes factors related to research and development, manufacturing, delivery, and uptake of vaccines. And so vaccine hesitancy, or the reluctance, resistance, or refusal to vaccinate, despite in some cases the availability of vaccines and vaccination services, is one of these factors that really make vaccine equity complex, but also something that actually needs to be dealt with, because it's having an enormous impact on vaccination rates against COVID-19, particularly in countries with widespread access to COVID-19 vaccines. But we also know in low and middle income countries, for example, here in the Africa region, even as supplies begin to pick up, it's really critical that we also work on the confidence side, on the uptake side, and really address the reasons or the factors that are contributing towards the hesitancy. So I'm really excited to moderate this conversation. We have a great lineup of speakers. My name is Rosemary Mboro. I'm the Executive Director of Waki Health, and we are part of the CASPA Coalition and also a longtime partner of AVAC. And before I introduce the panelists, I want to look to my colleague Mitchell, from AVAC, to quickly give us a word of welcome on behalf of the co-organizers of this webinar. Mitchell.
Great. Rosemary, thank you so much. And I know you haven't yet introduced Kate and Heidi and John, but thank all four of you for this conversation. It is at a critical moment, not only, as you said so beautifully, about COVID, but about global health and the way we build confidence in our health systems, in research, and in delivery. And I really can't think of four greater people to kick this conversation off. As you said, Rosemary, it's the first of an ongoing series to really unpack these issues so that we can all do better together. And I don't want to take any more time than that, other than to thank you all for helping guide this conversation, and really excited to hear from all four of you, but also from all of the attendees in as interactive a way as we can in what has become an all too common virtual reality for us. But with that, I'll turn it back to you, Rosemary. Just great thanks to all of you.
Many thanks, Mitchell, and thank you for organizing and convening us. So now very much excited to introduce the great speakers that we have. We have Dr. John Nkengasong. He is the Director of Africa Centers for Disease Control and Prevention at the African Union Commission. We have Professor Heidi Lasson, founding director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. And we have Dr. Kate Hopkins, Director of Research, Vaccine Acceptance and Demand at Sabin Vaccine Institute. I'm not going through the bios because I now want to turn to our speakers so that they can introduce themselves, do a brief self-introduction, but also share with us their perspective on the current state of vaccine confidence. So let me start with Dr. John Nkengason, Africa CDC, and thank you so much, Doctor. Here in Nairobi, I would call you Daktari, which means doctor. Thank you so much for the leadership, from the Africa CDC perspective that helps to galvanize political leadership within Africa for the continental response to COVID-19. We really much appreciate that and I applaud you for that. So kindly introduce yourself and share with us your perspective about the state of vaccine confidence from your perspective. Welcome.
Thank you, Rosemary. And let me also use this opportunity to wish everybody a very happy New Year. And a new year that is full of good health and safety, because we live in a very unpredictable and uncertain times with this pandemic. I would never have imagined in the December of 2019 that we will be fighting this pandemic way into the third year. And nobody could have imagined that. I remember when some lockdowns were going on, people said, well, for how long shall we do this lockdown? We said maybe 3 months or 6 months. And now we are into the third year. It only speaks to the importance of why we need vaccines now. Vaccines, as the experts, I feel also very intimidated to be on the panel with Hedi Larson, who is an expert in vaccine acceptancy or hesitancy, depending on what side of the coin you look at it, to be discussing vaccine hesitancy. I always thought, being a virologist for 30 years, that everybody will accept vaccines. Why would somebody argue with vaccines? Vaccines have saved my life. I think if I look at my vaccination card, I probably have received about 10 different kinds of vaccines that have led to my own personal survival. Why would somebody hesitate? So here we are with the COVID vaccine. So as a continent of 1.2 billion people, we have been able to immunize fully about 10% of the population. The definition of full immunization is people who have received 2 doses of the other vaccines or a single shot of Johnson & Johnson. So that number is very important, and because we should also just make a mental note that our goal is to get to 70%, okay, by mid of this year, according to the WHO target. So how do we move from 10% to 70% what we should be framing our mind in order to get out of this pandemic. Now, if you look at the media, the narrative that is emerging is that there's a lot of vaccine hesitancy in Africa. Yes, there is, but study after study showing that about 80%, an average of 80% of the population in Africa are willing to accept vaccines. The World Bank just did a multi-country survey. There's a study that has been published in Nature Medicine that speaks to that gives almost that the same level of acceptance. Then our own public health survey that we do regularly in partnership with the Resolve to Save Life and WHO also put the number at that. But you have a very noisy 20% or a very loud 20% of the population that is not is resistant to vaccine or has mixed views on vaccine. And this is where I'm hesitant to go into this, but I'll just say it and then let Heidi correct me. There's vaccine hesitancy, the way I've seen it over the last 1 year, is not static, that it is a moving process, okay? And I think we should be very careful that we do not use that very loud 20% of the population that is having mixed feelings to vaccines and to characterize the whole population. I've given some numbers and anyone can verify these numbers. Lastly, before these vaccines were available, Heidi and as part of the London School of Hygiene the London School of Hygiene and Tropical Medicine and Africa CDC conducted a survey of 15,000 people across 15 African countries. And at that time, we saw that the range of acceptance of vaccines ranged from about 60% to 95%. Okay, and we are seeing that, and this was before the vaccines, and we continue to see that trend hold in some countries like Ethiopia, where acceptance rates are very high, then in DRC it's low. It really confirmed that trend that we saw very early on in that. So in some, the vaccine hesitancy is not unique for Africa. It is a global phenomenon, but I would argue that, and I like that the audience should remember, is that it is about 20% of this population in some countries, it could be more, slightly more, that is doubtful about vaccine, and we should be very careful not to characterize that as the driving force across Africa.
Yeah, thank you very much for sharing that reflection, particularly about the percentage of population in the Africa region that is hesitant, that, is hesitating to go for COVID vaccine, and not just COVID vaccine, but also I think a really great point there about the fact that hesitancy is also varies by geography, and you have shared that even within Africa, it varies from country to country, but also within country, it varies from region to region within the same country. Thank you for that. I'll turn to you, Professor Heidi, to hear your perspective on the state of vaccine hesitancy.
Great, thanks very much. And John really put his finger on it by saying that it's not static. I think when I was thinking about, if I had to answer a one-word question in the elevator about what's the state of things, I think I would just say volatile. It's true that overall about that 80% willing, 20% kind of loud and on the margins, but influential, is there. But where that 20% is also moves. And I think that one of the biggest learnings that we've had in COVID is those numbers are, as you can see with a lot of surveys in other countries, they keep changing, and they change locally. And we need to be on our toes. We need to be nimble. We need to be responsive, and we need to be understanding why they're changing. The survey that we did with John in 2020, there were a few places that we followed with some multiple waves. For instance, in Nigeria, and during March, when some of the early suspected side effects for one of the vaccines in Europe was hitting the news, we saw every time a piece of news came out, that changed in almost the same day, which was, the speed of which things are moving was really striking. We're about to, and I'm very excited about it, in the next couple of weeks, roll out another follow-up study in multiple countries with some follow-up waves, and in a few countries a bit more subnational, just to partly look at how things have changed over that time, and they've probably changed back and forth a number of times since then. So I think everywhere in the world, the good news is that people can change. And so that should give us optimism for increasing confidence. But we also can't assume that because someone is positive and confident one day, we can just move on to the next community and forget about that one. It needs constant nurturing. And I think that that's one of our lessons, which also is that this is about a relationship. It's not about information. It's about trust building. And if you asked me what the key things were that mattered, I would say three things: trust, trust, and trust. And that's trust in the provider, the healthcare provider, that's trust in the politics, and that's trust in the product. And if you don't get that aligned and put people in the middle, we're just not going to get there. But we're on our way, and I'm very excited about what's ahead. It's a super important year for Africa, with more vaccines coming down the pipeline, which will test our surveys, because we do see too that people can say they're hesitant or willing, but you don't know till it's in front of them. And I think that particularly in Africa, we've seen some places that have reflected a hesitancy, but once the vaccines were available, they were lining up.
Thank you very much.
And I'll also just add that when people saw the waves come, we've seen increased vaccine uptake when the waves have come in, and they lead to increased number of deaths. People rush for vaccines, and as if vaccines are treatment. So I just want to add that as well.
Yeah,
that's a really great observation there. And Heidi, you've introduced us to a really important term. I'll call it a terminology, trust, the issue of trust. One of the things that even we as advocates ask ourselves is whether, and maybe it's something you can reflect on, either of you can reflect on down further along in this conversation about the language itself. Is it vaccine hesitancy? Or are we better placed to talk about vaccine confidence? Or is it, an issue of trust, or a combination of all those? I'll turn to you, Kate, for your quick reflections, or share your perspective on the state of vaccine hesitancy.
Sure, and I'm delighted in this opportunity to join this panel, so thank you, firstly. I guess just to echo sentiments of John and Heidi, I want to kind of bring up that the WHO intra-action reviews, which is kind of a state of play for the COVID-19 vaccination rollout, have stated 6 best practices, and one of which is evidence-driven approaches. And it comes back to what both panelists have said regarding nothing static and this notion of trust. So I would say, vaccine confidence is a global issue, but again, we can't make broad brush assumptions of the drivers in one place versus another. And we really need to understand the unique nature of the issues and develop innovative community-informed approaches to strengthening vaccination success and gaining trust in communities. And so within the Save and Vaccine Institute and the Vaccine Acceptance and Demand Initiative, that is exactly what we are trying to do as we engage with multidisciplinary stakeholders to implement intervention-based and action-oriented efforts, which include the design, testing, and piloting of specific interventions to really get to understand what is happening on the ground and understanding the evidence stemming from strategies we're striving to generate. And I think the more that happens, the more that we can fully understand localized contexts and get towards this 20%, right? Getting people to become more confident in the systems, in the product, in the providers, and really start to look at increased uptake.
Yeah, thank you very much for that, and really also for pointing out to community-led approaches. When you say that, it's an amazing sound and music to our ears, because we know what community-led approaches can do in terms of uptake, in terms of mobilization, and many times in these programs, we forget to include community-led, community-informed programs or interventions, and that really is a key pillar that determines how successful a global health initiative is going to be. So thank you very much for pointing out to that. I know we have quite a number of questions from participants. Some of them came as they were registering. We want to thank and appreciate all the participants for that. And even as the conversation goes on, kindly feel free to drop any questions that you might have. We are unlikely going to have the time to address all those questions, but we'd like to see the kind of questions that we have. Some of the questions already point to some of the challenges that or like the causes, because we have questions like, are vaccines safe? questions like, that are really pointing to the question of trust as well. But we won't go to the questions yet. I would just want to turn to you with some initial questions or another round of questions. You've already pointed out to some of the key drivers of vaccine hesitancy. We would like to hear more about that. We've talked about the numbers. We've said that really it's there, we have a percentage of the population that is actually hesitant about the vaccines. What are some of the key drivers from your perspective, from where you sit, from some of the literature you have reviewed or research that you've come across, the key drivers of that? But also, what are some of the levers available to build confidence about vaccines and vaccination? So I think we can look at those two, and perhaps I come to you first, Dr. Nkengasong, to look at, to share your reflections about those two questions.
No, thank you. I think there is some scientific evidence to suggest that several factors or a combination of factors lead to vaccine hesitancy. One is misinformation. We've seen during the lifespan of this pandemic that there's been a ton of misinformation out there, and which has been driven a lot by social media, where people receive information on their social media outlets and they just spread it. And it grows like wildfire. And of course, we cannot underestimate the impact it creates on informing people's opinion. Okay, I think that is extremely important. The second thing we have seen is the unpredictability of access to vaccines. You see that in April timeline, for example, in Africa, the continent was very mobilized to receiving vaccines. They received the first set of vaccines, the AstraZeneca vaccines, then there was a disruption. When you have that uncertainty in vaccine, access to vaccines there, it creates suspicion. And no matter what you tell people, people just don't care. That you begin to, you ruffle that trust capital that Heidi mentioned there, because you tell people that, look, your AstraZeneca vaccines will come in, go there, get your one shot, and after 4 weeks, get the second. Then they come back to you and say, well, when do we go for it? Then you start telling them stories about, well, India has this other thing and whatever. Then you rupture that trust capital, which you should not be doing. Of course, thirdly is just especially in Africa, what I call socio-cultural context, where people believe there are certain segments of the population that just don't believe that COVID is there. And if they do so, they think that it is something that is for others, not for them. And that is what informs what we see when the wave of COVID emerged, and you see people rushing to go get their vaccines because they see their loved ones dying. During the first wave of the pandemic early last year, it was difficult for an African to point to somebody who has died of COVID. During the second wave, you see that tendency changing, where people started knowing people that have died of COVID. And during the third wave, many people knew many people that have died of COVID. So the rush was to get that. But when the third wave came down significantly, that attitude changed. I mean, that is the vaccine-seeking behavior diminished. So it's always a combination of all of these factors that account for that.
I guess to kind of build off of what John just shared, I completely agree. I mean, I think key drivers of vaccine hesitancy are social and behavioral related, and then complemented with more structural and health systems related components. There's the what and the how people think, feel, and perceptions related to vaccinations. And that is very much influenced by social contexts. And you have this kind of overarching structural component of cultural norms, social norms, religious and political ideologies that also affect a person's beliefs and then kind of filter into someone's motivation and intention to vaccinate. So those are key drivers. And then the structural and health systems related, which have already been mentioned, that are largely convenience and access to vaccines and the issue of supply. What we're seeing, that if you want to kind of go more granular, and we touched upon trust already, but there are key drivers of vaccine confidence and trust. And what we've been seeing from partners on the ground, is this infodemic, this rumor milling, mis and disinformation, and that's paired with how far that kind of permeates into a person's belief system or a community is also been shown to be correlated with levels of science and health literacy. Other drivers that we're seeing are in certain areas are distrust in local governments, and that can be linked to political history or perceptions and how the pandemic has been handled. Different areas have had differing reactions, such as mandated lockdowns, and goes back to supply. And then there's also been distrust in foreign governments and international health agencies. So, and that's not necessarily a new driver. We've seen that there's a history of that within low and middle income countries, distrusting imposed, Western medicine. So it goes back to just the real importance of understanding the localized context and really empowering local communities, to kind of inform solutions to drive increase in vaccine acceptance.
Yeah, thank you for that, Prof. Heidi.
Yeah, I think of the levers as being, they're as being far more emotive than we often want to talk about. It's really not just about individual emotions; it's about group emotions. And I think what John had talked about in terms of the uncertainty and unpredictability. There were a lot of studies actually on rumors during the Second World War. It was kind of the birth of some of the more scientific research on rumors, because there were so many of them then. And one of the classics written, called The Psychology of Rumor, said, where there is no ambiguity, there's no rumor. And the context of the pandemic is hyper ambiguity, uncertainty. And I think that is, people try to make sense of things. The denialism that also was mentioned before, this can't be true. We saw it at the beginning of Ebola. I saw one wall that said, using the campaign to say Ebola is real, and another one more recent, COVID is real. We saw it at the beginning of AIDS. When it's something new, you can't put your hands around it. Also, when the actual symptoms manifest themselves in so many different ways that look like other illnesses, it's kind of hard to say, actually, this is COVID. Your brother didn't die of stroke, it was COVID. And then the suspicions and conspiracies around, the vaccine industry trying to sell more products. But I do think that in that sea of all of that, people do try to make sense of things. They are trying to understand what's the right thing to do. And I think we can't underestimate the power of belief. Religion is a huge, it's both an enabler, and also when you get a religious leader or you get a president, like the president of Tanzania, who was looking for divine intervention and had people, in the churches praying to be through this. That's, leaders can be powerful influencers, local and political. So I think we can't underestimate the power of belief. And if we can we learn this in polio, we've learned this in different contexts. The more we go where people are, the more we go and understand who the trusted colleagues are, the better. But I do think we can't one thing that's really struck me in the context of Ebola is there's a lot of things I thought about, and I wrote in 2018 a commentary in Nature that was one of the biggest pandemic risks will be viral misinformation. Well, it was way more than I even expected. But what I didn't expect, and what has been, I suppose it shouldn't have been a total surprise, but the number of political national leaders who have not been helpful, who have not, in the face of massive death and an emergency, not come together and said, we need to make this, we need to work together on this. And that's where I think the exceptions, the creativeness, the small successes that have kept me motivated are local, are in communities, are with groups that have, despite all the contrary and disinformation environment, are saying we've got to come together and get through this.
Yeah, thank you very much for that. One of the things you mentioned actually resonates with what some of the participants are saying in the chat. There is Dr. Ainon who makes these comments to say that religious leaders are key in hesitancy mitigation, and gives an example that in Jerusalem, we have seen their impact on COVID-19 vaccination with Christian, Muslims, and Jewish faith leaders. So, and gives a link for colleagues who are interested to follow that discussion. So really critical issues here. So it seems from this conversation that it's not very clearly, it's not a one-off intervention when it comes to building vaccine confidence. It's not something you go in and out. It's a process. It's something you build over time. And I take note of comment Ida as well, saying that even as we talk about trust, it then seems that it's like a long-term project, because today there is trust, tomorrow that trust wavers because there has been change in the political leadership. There has been some changes within the health system, and that affects people's trust. The question then that we might have is, to what extent do we think COVID-19 vaccine has impacted general vaccine programs or vaccination? To what extent has that affected what we are seeing? And what Dr. Nkengasong was saying is that, when there is a wave, there's a rush to get the vaccine. And when that goes down, we kind of sit back and wait for the next wave. So generally, how has the COVID-19 vaccine hesitancy affected general vaccine programs or perspectives of vaccines among populations? Any reflections, views on that? And then we're going to come to the Q&A. I see we have quite a number of questions. We've not forgotten you participants. So Kate, Heidi, Dr. Nkengasong?
Maybe, Kate, you want to go first, or Heidi? I don't know. Yeah.
Sure. Well, I just think we've seen there's evidence on the ground that it's greatly impacted routine immunization. There was a study in Kenya that showed babies born within the pandemic, only about 60% of that study population, those babies were fully vaccinated. Whereas in 2018 or 2019, just before the pandemic, more than 90% were. So it's definitely having an impact in early childhood immunizations. And I've heard recently, yesterday, partners on the ground in India who are in the thick of this third wave. They've had to basically drop a lot of their routine immunization programs to fight this COVID battle. So we are seeing a lot of it's negatively affecting routine immunizations and this this population of zero-dose children. So yes, there has been an effect.
But I think the effect has been more in the access area because of COVID, people anxious about getting infected if they go to the clinics being overwhelmed and focused on COVID. So I think I don't think we're really going to know in terms of its impact on sentiment, on confidence, until we get to the other side of this. On the other hand, I think how well we do with our trust building will be absolutely crucial. We can use this time to build those trust relations, and people who were more hesitant before might feel like, wow, well, they treated me well, and I'll come back for my kid's vaccine. Or people who were good vaccinators before felt like they were really mistreated and lost their trust. So I think that the jury's out a bit, as they say, in terms of the sentiment side of it, but absolutely the access issues have taken a toll. And just to cycle back on the earlier question, Rosemary, that we didn't really answer, unless I and maybe it was woven in there and I just was this question of whether hesitancy and confidence are interchangeable, but no is the short answer, because hesitancy is a state of indecision. It's whereas confidence, you can be 0% confident and 100% confident. And why I've picked it in the confidence project was because, one, it sounds more hopeful, but two, you have a longer spectrum, and hesitancy is somewhere in the middle. And it's leveraged by trust and confidence, but they have been a bit used interchangeably. I would almost say that if you're confident, you're not hesitant, but it's not that straightforward. It's sorry to make it more complicated.
No, I completely agree with your definitions. So the term vaccine hesitancy, I know Sabin, and we encourage a lot of our partners to actually use the term vaccine acceptance because it sounds more positive. But
vaccine what?
Vaccine acceptance rather than hesitant, because it sounds more positive, but also it steers it away from the term vaccine hesitant. Can almost seem like it's placing the blame on the individual, whereas there's a lot of other contextual factors in play. And I feel that vaccine acceptance is on a scale. I mean, it's a vaccination behavior, whereas vaccine confidence is in relation to trust, and it's a lot of it's based on a lot of perceptions.
That's really helpful in terms of unpacking those questions and the terminologies, the language that we use. And Kate, one thing you pointed is that you can use language that actually sort of victimizes the person who is actually not going for the vaccine, blames them, and we've seen that a lot of this is a question of also how we understand the science, how we understand the vaccine, how we understand the whole array of things, because remember we said it's not easy, it can be very complex, and more so when we don't explain it well to the public, to populations, to different groups. I think it can lead to that. So that's really great to know about how different terminologies can the kind of reaction they can bring about. Dr. Nkengasong?
Yeah, I just wanted to, I know you want to segue to the question and answer sessions there. Before we at least move from this phase of a conversation, just to show that I, at least in my 30 years experience in public health, seen how products are used or uptake in the field. There are usually three categories of people that in the population. That is the spirit of know your population. Okay, we used to say in HIV, know your HIV, know your population. Is you have innovators. These are people that who take part in the vaccine clinical trials, right? So a vaccine is not yet there, it's not approved, but they are our saviors. They are the people that will show their hand up and say, good, give me that drug. And if it works, it will save mankind. Those are the people that create, that are really there. They are there. How do we get 30,000 people to get the vaccines? Then there are early uptakers. That is the people like you and I who say, wow, this vaccine is 90% efficacious. Where can I get a shot? You rush to that place and you get it and you get that. And then you get to the group of people that are reluctant, call it, all the terminology comes in this group of people, reluctance, doubters, acceptance, and whatever. And that is where public health really should focus. Okay, you public health had no business in the innovators, okay, because they are already there. Public health has no business in people that the early takers. They are, so you really want to focus on that group. So we should really see this as the real public health focus of our time to work there. And it's not, it's very similar to smoking and lung cancer. We know that people smoke, but we've never given up on educational, informational programs that says to people, if you smoke, you get cancer, diminish smoking. We should really focus on that rather than acknowledge that it is there. We really do something with it and find innovative ways to bring the people. And the choice of word is important. If somebody is a vaccine doubter or a reluctance, it means that with the appropriate messaging and engagement, you swing them over, you bring them over, you build confidence, you bring them over there. So the word that with choices of words in that category of people is extremely important. I just wanted to underscore that before we segue to the next session.
Thank you for that. I'm seeing a lot of comments also that relate to that about education, how we message, and really getting people, populations, communities to understand. So that's a really critical piece of this discussion. And I'll turn to the Q&A for a few questions, but also I think coming back later, we would like to hear from the panelists, but also from the participants. If you're here, please, you can use the raise hand function. What do we do about this? Are there certain policies? Are there certain tools? Are there certain resources we need to tap into? We are discussing a particular challenge, which is vaccine hesitancy, confidence, not adequate acceptance, and all that. So we know the challenge. We've looked at the causes, but what do we need to do? Are there certain policies, certain tools, certain resources or recommendations that we can actually put forward as we address this? And also to communities and civil society representatives here, what are some of the effective community engagement mechanisms or initiatives? How does that look? Because it has been identified as a key component of building confidence. Do you have examples that you can share here? We don't have much time, but we'd really like to hear on recommendations or things that have worked. So I don't know, Mitchell, I'll turn to you. We have quite a number of questions here. Whether from the participants' questions we can raise a few of those before we go to the recommendations.
Yeah, no, I think that sounds great, Rosemary. And I think this issue of best practices that came up in a couple of different questions, and maybe if each of the panelists could really comment a bit on what's actually worked in the last year or so.
I think we should be thinking more about best processes rather than best practices, because the practices, there's no real, because of the nature, the changing and evolving nature of this, because it's about sentiments, emotions, opinions, they change. And I think that we used to have, these set of best practices and KAP studies that you'd keep on your desk for, I don't know, a couple of years even. And it's just not an option anymore. Things are changing so quickly. So I think we should be thinking about best processes, meaning starting from listening, starting to being alert, starting to being responsive, being nimble, and thinking about ways that, mapping who are the trusted, understanding. We, in our Ebola research, when we were supporting the introduction and trials around Ebola vaccines, one of the three themes that we heard again and again were power, fairness, and trust. Do we feel like there's a power balance? Is it fair? They didn't have a problem with things like randomization, or a lot of communities were happy to go along if they felt it was fair. We've seen that a lot with COVID. So I think some of the principles, maybe best principles and best processes, because I'm really shy of saying that anything's a best practice today when you know it could change.
Mm-hmm. No, that's helpful. And I wonder if we know, we have experienced or have seen any best processes that we might want to take forward, or any recommendations. One thing that have come out very clearly is around community engagement, making sure we get that right, making sure that communities are at the center of that. I've also seen quite a number of colleagues comment about really thinking about education. How do we explain the vaccines? How do we roll it out? And then also the structures we use, including some of the socio-cultural structures that we have, whether it's through the churches, through the informal settings, et cetera, et cetera. So just looking to see, Kate or John, whether you have any thoughts on that. I've seen most of the questions or most of the comments are actually, most of the activity on the chat are actually comments in support of the conversation, but I'm looking to see if we have colleagues who have questions that we can take, maybe one. But over to you, Dr. John, Heidi, Kate.
No, sure. Let me say this, that I remain very hopeful that this is a challenge of our time, and a challenge that must be dealt with from a public health lens, and that we have several tools in our disposition to do this. One is community ownership and community leadership, and that includes the role of religious and faith-based organizations, I think, and civil society must play a role. When we just to use our own personal experience from Africa CDC, we did, as part of our Saving Lives, Saving Livelihood initiative, which is a partnership with the MasterCard Foundation, we went to Cameroon and a church in the northwestern part of the country, and we had a discussion with the priest or the preacher. And all he did was to, at the end of the church service, to announce that vaccines were next door, which is we've brought in a mobile truck and put out there. So just make a mental note of bringing the vaccines closer to the people and not people to the vaccine site. So he was convinced, he was vaccinated himself, and he made an announcement at the end of the church service that vaccines were outside, people were interested, should really, and encourage people, not just put it passively, but actively. And I have a slide of this that I would like to show in one of my presentations, not now. You could see the crowd. Nearly everybody who left that church service was out there in the next door getting vaccinated. So there were two things that were in play here. One is the trust factor in our religious leaders or community leaders. Second is proximity of the vaccine. So if this religious leader had said, go out, find wherever you have vaccination sites and get them, you probably get 20% of the population going to be vaccinated. But because he said that, and people stepped out of the church and saw a vaccine center, it was a long queue there for vaccination. So two things I want to leave you with there is that religious leaders are very important, and civil society leaders are very important. Make it accessible. Don't make people work too hard to find the vaccines or go to the vaccination site. If I have to get up in the morning and cross the city of Nairobi and go to the other end of the city to get vaccine, then I begin to think I can postpone that decision, okay? Because I'm not sick, okay? I'm feeling healthy. I think I'll do it later and whatever. And then we characterize these people as vaccine hesitant and see or doubters there. So I think that is extremely important. Third, and lastly, is the champions. We really have to find some champions that are both that emerge from a variety of the entire spectrum of the society. For example, you really need to come to Nairobi. I'm using Nairobi because Rosemary, I suspect you are in Nairobi. If our goal is to vaccinate the motorbikers or the bus drivers there, then our champions for that should come from that community, right? I mean, you as a public health expert, you really have little influence in that community, because it may look like they are terribly disorganized, but they are very, very organized. Okay, everybody knows everybody, and they eat together, they communicate, they have a way of communicating. So we find the champions in sub-communities that will enable us to have a good penetration and build that confidence and trust. So I think that is, those are in the spirit of finding solutions going forward. We've done the diagnosis, but in the spirit of providing cure for the problem, those are some that I will offer. I'm sure Heidi and Kate have many more.
We've seen similar examples from partners on the ground deploying those efforts and then being successful. I think best processes or better processes can come through social listening, and that can be both through more aggregate data using social media platforms, which can kind of understand, what the themes are that people are talking about, what kind of misinformation is there, and then you can stratify it through demographics. The only problem with utilizing social media platforms is that it can leave out populations that aren't digitally literate. So then you need to pair that with this hyper-localized approach of community engagement, which we've seen successful on the ground being community-based participatory approaches. And by doing that, you're bringing in key insights from the community members themselves, a lot being community influencers. So we've already talked about, religious leaders being influencers. In certain communities, are they teachers? Are they community health workers? They can vary by setting, and kind of tapping into the experiences of these people to help strategize, first understand the baseline data, and then strategize key interventions and co-create and co-design key messages, health messaging to the community. And what we've learned through systematic literature reviews is that what can increase vaccine acceptance and build trust is by these community influencers relaying targeted messaging. So, what are the issues, and then train these people on communicating factual information geared towards the community's needs. And then understanding so it's both the messenger and the appeal. Examples of that are, we have a study in India that kind of brought the notion of, and it's widely known that in South Asian communities, listening to the advice and respect for your elders is really ingrained in the culture. So the messaging, primarily, it can be successful if targeted to the elders in the community. You have other cultures that, are very patriarchal. So, the decision of a household to vaccinate will set within what the decision of the male head of the household is. So I think you really using community members and community influencers to not only target people in the population, but then understand the contextual factors and kind of create targeted messaging is a better and best process.
Thank you. Thank you.
I would just add one thing, and that is to put vaccines in context, because I think we have to remember people are going through all kinds of things right now, and it's really important just to ask people, how are you doing? What are your, we were there at the end with polio, where people were fed up of hearing about vaccines all the time. And they, once you started to say, well, what else do you care about? What else do you need? And then it was like, just give us some clean water, or help us with X, Y, or Z, whatever. And just even that gesture of asking, never mind trying to help them address other issues in our COVID recovery, are going to be really important. We did actually an exciting collaboration with YouTube where it was called Get Back to What You Love. And it was a whole series of short clips of people, a grandchild running to hug their mother, some, in the Caribbean, some people dancing, and somewhere else it was little clips of things you love that during COVID, were more prohibited or inhibited. And then at the end, it just had the logo, Vaccine Confidence Project, and then a link of where you could get more information. It didn't say, go get vaccinated. It's said, get back to what you love. And I think that what will be important if we want to keep the conversation going and not, it's been a lot of conversations about vaccines. Don't drop that conversation. But I think the more we can send a message that we really care about what else is going on in people's lives and, trying to think about ways to get them through that, including helping getting their kids vaccinated, because I think a lot of these parents really want to get their kids vaccinated, or whatever other health need. But just to come back to that, putting it in context.
Yeah, thank you very much for that. And to all the campaign that Hedy mentioned, Micho has put a link to that on the chat. Thank you for that. I see you, Jim Pickett, that these are all great suggestions, lessons we can use in terms of HIV prevention as well. So this is really great, and we've ran out of time. There are still many questions and many comments. I see you, my colleagues, I see your questions, but this is just the beginning of a series of conversations. So we'll look at what are the emerging themes and what do we need to keep going forward in terms of the conversations. It's really been great in terms of the thoughts, the insights, the ideas, the examples that have been shared here, from language, from what we can do, from what the challenges are, looking at how do we actually make this work? How do we ensure that vaccine equity works, and building confidence, in fact, among communities everywhere, globally, basically, is one component of that. And so thank you very much for those insights, even for the recommendations of what can be done. That came both from the speakers, but also from the participants in terms of education, in terms of how we can do better work at targeted messaging, in terms of champions that we can build, we can tap into, and how we can really rally together and make this work. Ultimately, what we want to do is to have a shot in the arm and to make sure that everybody can access that, which begins from understanding the science, appreciating the science, embracing the science. And I think we have to do a better job at that as well. I think one of the questions that we must answer next time is, we've talked about trust. It takes a process. It's not a one-off activity or intervention, but there's a big question in the chat. I think I've seen it twice or thrice, but what happens when there's no time? What happens when you don't have time to build the trust? You are in an emergency response situation, some crisis, and you really want to build vaccine confidence. What happens when there's no time? We've come to the top of the hour, so we don't want to extend this any further. Just in terms of respecting your time, everybody, I want to thank you on behalf of the co-organizers, the Community Advisory Board, CASPA and AVAC. I want to thank you very much for being here, for the insights, for your participation, and we'll keep you updated on when the next session is going to be. Thank you very much. Micho, I don't know if you have any final thoughts, reflections, closing.
But Rosemary and John and Kate and Heidi, thank you. I do think, and if the panelists have another minute, want to maybe give a final thought, that would be great. I do just want to say, I think this issue of building for the long term, the processes, and I think starting where Heidi, or going back to where you started, Heidi, trust is not necessarily built overnight, even in a pandemic, but how do we build a culture and a community of trust on an ongoing basis in research, in health systems? Because and Rosemary, you said it, it's not just about COVID. It's not just about any one pathogen. It's about health and health equity writ large. And so we're delighted to have this conversation kick off. And thank you, Rosemary. And don't know if the others have time for a quick closing comment as well, but just with great thanks.
Yeah, I think, Misha, let me just say that the underpinning for our health security, as the whole discussion continues to be sustained about health security, is understanding the population. So I say this because no matter what kind of innovations we have on our left side, we have to be able to move that innovation to the right side, which is the population, so that we avoid getting into the value of death, okay? And without the population, the trust within the population, regardless whether it's vaccines or drugs or any intervention, they will always be excited on the development on the left-hand side, and then we suffered on the right-hand side. I think that's what we are seeing with vaccines. And it's not only in Africa. In the United, the study I mentioned in Nature Medicine showed that countries in Africa that were sampled had a higher acceptancy level for vaccines than many other countries in the developed world. So I think building that trust in public health in peacetime is what is going to drive us in a wartime when we're dealing with crisis there. I mean, you don't make your friends when you need them. You make your friends before you need them.
Yes. I think that's the best note to end on. I think I made my comment about keeping in context, and I think that was a perfect point about the security context. Thank you.
Great. As Rosemary said, stay tuned for our next, and I some great comments here where we will follow up. This was meant to be fodder for the series, and you all have, not just the four of you, but all of you on the line have helped create that fodder for the next set of calls, and look forward to working with everybody going forward. Stay safe and well, and trusting and building trust.
Thank you very much.
Thank you.
Cheers all.
Bye. Bye.